My name is Byron Ford. I'm a professor of biomedical sciences in the UCR School of Medicine. I'm also Associate Dean for Pre-Clerkship Medical Education in the School of Medicine. My research involves neuroregulin regulation of neuroprotection and neuroinflammation following ischemic stroke. Blood enters the brain via carotid arteries in the neck that branch into the cerebral arteries. These include the anterior cerebral artery in the front, the middle cerebral artery in the middle, and the posterior cerebral artery in the back. Stroke occurs when one of these arteries is blocked, or an ischemic stroke, or the blood vessel ruptures, a hemorrhagic stroke. About 80% of strokes are ischemic strokes and are usually caused by a clot that blocks the blood vessel. When the blood vessel is blocked, the brain tissue fed by that artery dies over the next few hours or days. You can see in the cartoon that the shaded area indicates brain cells that are dying on one side of the brain, while the other side of the brain is relatively normal. There is a significant need for the development of novel stroke treatments. There are approximately 800,000 strokes in the US per year and 15 million worldwide. There's only one drug approved for stroke, tissue plasminogen activator, or TPA, which is a clotbuster drug. The drug works well, however, it can only be used within 3 hours of the onset of the stroke and completely is contraindicated for hemorrhagic strokes. It has to be administered in a hospital with a certified stroke program for safety reasons, and as a consequence, only about 3 to 5% of stroke patients qualify for TPA. Endovascular thrombectomy is an alternative strategy where the clot is physically removed by a clot retriever and has a window of 6 to 24 hours. In my laboratory, we model stroke using a surgical procedure in rats and mice to block the middle cerebral artery. We insert a filament with a silicone-coated tip into the internal carotid artery to block the middle cerebral artery. You can see in this figure, we can measure cerebral blood flow in real time. And when the filament is inserted to block the MCA, we can see that there's a complete reduction of cerebral blood flow. And when we remove the filament, cerebral blood flow is returned to normal. You can see histologically that brain damage occurs after stroke. In this rat section, red indicates living tissue and white indicates the tissue that died after stroke. You can see that there's a large area of damage on one side of the brain where the other side of the brain is relatively normal. We also use a photothrombotic cortical middle cerebral artery occlusion model in our studies. In this model, a photosensitive compound, rose bingo, is injected into the vasculature. We shine a laser light at 532 nanometers onto the skull to induce a clot in a selected area. In this laser speckled image, you can see that a branch of the middle cerebral artery, pseudocolored red, where the blood flow is high. After stroke, in the circled area, you can see that that same blood vessel, pseudocolored yellow, blood vessel has been completely blocked, indicating that a stroke has occurred in real time. For the past 20 years, my laboratory has studied the usefulness of neuroregulin-1, an endogenous protein, to protect brain cells following stroke. My lab and others have shown that neuroregulin signals through ErbB receptors, which work as homodimers, and depending on which dimers are present, can signal in different ways to facilitate proliferation, cell survival, growth, and inhibition. My lab was the first to show that neuroregulin was useful in protecting brain cells following stroke. As the previous cartoon showed, when the middle cerebral artery is blocked, brain cell damage occurs on one side of the brain while the other side of the brain is relatively normal. Correspondingly, you can see in rat brain tissue, the red indicates surviving cells where white indicates areas of brain cell damage. When we treated brain cells with neuroregulin, either before or after stroke, it resulted in a 90% improvement in neurological function. In fact, neuroregulin reduces brain damage when given up to 13.5 hours after the stroke and improved neurological function. There is significant clinical opportunity for neuroregulin-1 in the treatment of ischemic stroke. Neuroregulin would be first in class as a neuroprotectant to treat stroke. Neuroregulin could also be delivered in an ambulatory or emergency room setting due to its safety profile. Neuroregulin could also be used as a prophylactic for cardiac surgery, for subarachnoid hemorrhage-induced vasospasms, and to prevent post-stroke infection. Importantly, 2 neuroregulin isoforms are currently in clinical trial for heart failure. Neuroregulin was shown to be safe in phase 1 clinical trials and was shown to improve cardiac function in phase 2 clinical trials of patients with congestive heart failure. We are currently working towards developing clinical trials for stroke in collaboration with Riverside Community Hospital. I would like to thank my current and former lab members for their assistance with this work and for funding from the National Institutes and other funding agencies. Thank you.